My name is Alan Higgins. I'm the Health Equity Network lead. We have Alison Beedron, who's the Health Equity Network coordinator. And welcome to today's webinar, where we're looking forward to the general election this time next week. And we have invited three speakers to give us their thoughts about what they would like the next government to do to improve health equity across the UK. And we have speakers, Sumi Rabindrakumar from the Trussell Trust. Sumi is the Head of Policy and Research. And then we will have Jessica Allen, who's Deputy Director here at the Institute of Health Equity. And then Hannah Davies, who's Deputy Chief Exec at the Northern Health Science Alliance, but also Executive Director of Health Equity North. And each of our speakers will speak for 10 minutes, and then we'll open up for questions. And usual rules of being on a webinar apply. If you can go on mute when you're not speaking, and then you can come off mute. And you can also post questions as well as comments, as well as introducing yourself in the chat, and we'll come back to those. We do encourage people to stay on screen as much as you can, but if you can't, then that's fine as well. Right, so no more to do. I think we'll go to Sumi. Sumi, would you like to give us your 10 minutes worth on what the next government should do for health equity?
Of course, thank you, and thank you for the invite. Just by way of background, I'm sure you all know, but Trussell supports a UK-wide network of food banks, and so together we do a lot of advocating for change to end the need for food banks in the UK. But while we're still needed, as I'm sure many of you see in your communities, we provide emergency food and support for people who are locked in poverty. You'll all be familiar with the interconnection between health and poverty, so I won't labour that point, but I thought I would start with painting a bit of a picture of where we are. And so at Trussell, we keep hitting these sort of depressing records, and our latest data shows that in the last financial year, so 23-24, we again hit a record high in terms of the number of emergency food parcels we distributed. So there were 3.1 million emergency food parcels distributed in the Trussell Trust network across the UK last year. And that was almost double what we were distributing 5 years ago, while the size of the network has remained pretty much the same. So that gives you a sense of this kind of year-on-year escalation of need that we're seeing in our communities. Over 1 million of those parcels went to children, so that reflects that we see a lot of the need that we see is about families with children. And then the final reminder is, as kind of stark and we would say shocking as those figures are, they are just the tip of the iceberg. So there are lots of independent food banks beyond the Trussell Trust network. There are other forms of community-based sort of food support or subsidised food support. And actually what our data shows and what sort of national surveys show is that people who are experiencing food insecurity actually don't access any kind of food support at all. So there are lots of people who are still struggling in terms of being able to afford food and put food on the table, but they actually aren't showing up in data sets like ours. So our kind of data set is kind of the canary down the mine and a red flag, but the need goes much wider than that. And so when we have the starting point and we have a vision that we want to end the need for food banks in the UK, we know from our data that we commission that the public is behind that. They don't think that food banks should be a reality in the UK. When we then think about what a new government could do and should do, I think that first our starting point is that we know who needs to use food banks and who is going hungry in the UK. We have lots of data, we've collected it over a number of years. There are some groups who bear the burden more than most, so that's particularly disabled people, carers, people from minority ethnic groups, people who are LGBTQ+, and families with children, particularly single parent families. And second, we know what has got us here. And so we've done a lot of work over recent years looking at what the data shows, speaking to people who come to our food banks, doing lots of participatory work, so lots of sort of grassroots work as well. And there are kind of common themes that come up time and time again. Social security is inevitably the big one. So there is a big theme around income simply not being enough. and social security being a big part of that puzzle. But also the flip side of that is that work is often not enough. So there are a few food banks in our network where actually increasingly the uptick is about in-work poverty, and sort of insecure work that doesn't provide enough hours to provide an adequate income is a kind of live issue for us. And then the other kind of broad area of themes that crop up a lot are kind of what we would call the sort of conditions of financial security. So some of that is about access to healthcare, some of it is undervaluing caring responsibilities, unaffordable and insecure housing, and also a sort of weakened community networks. So social isolation, digital exclusion, transport costs, all of these things are serving to kind of pull people apart and sort of isolate people from the networks, which can then have a knock-on effect in terms of things like getting into work, accessing the support that they need, and being in a position where they can then afford the essentials and wouldn't need to access a food bank in the first place. So we know who needs support, we know what would help turn the tide. We also know that that's a really big ask to end the need for food banks. So we put out a manifesto with that in mind, because what we want to concentrate the new government, the next government's kind of mind on, is that it's not enough to kind of kick the can down the road and sort of wring our hands and say, oh, we know that this is a bad thing, we know it shouldn't happen, but it's all a bit too big and it's a bit too difficult. So we've kind of put forward some concrete steps that we think would get us towards the point of at least starting to see a downward trajectory rather than this kind of continual year-on-year increase. And so there's kind of three broad buckets of what we want to see. One is around ensuring that people have enough incomes. So social security is a big one for us. We've been working with the Joseph Rowntree Foundation, calling for an essentials guarantee within universal credit, which would mean that there is an income that is guaranteed through our main social security system that would allow people to afford the essentials. And that level of income would be independently assessed, sort of taking the politics out of how much should social security support be. That's an expensive ask when we think about where political parties are at the moment. So what we have done is provided some kind of steps along the way. So there are things that you could do that would embed the principle that there is a threshold below which people shouldn't fall. So that's things like reducing the impact of deductions from benefits. So income is kind of clawed back from benefit payments to repay debts, often to government itself, because people take loans out for the 5-week wait for universal credit. We think that the impact of that should be softened, and there are very easy ways that you could do that. We also think that there are deductions that are built into the rules of universal credit, which should be ended as soon as possible. So things like the benefit cap, the 2-child limit, those are obvious ones to look at. We also think that there should be a lot more of a focus on local crisis support. So during the cost of living crisis, there was the Household Support Fund. Prior to that, there was sort of a patchwork of kind of support called local welfare support. We think we can look much more carefully at a long-term funding plan for local government to be able to be that sort of community safety net. So not just relying on national social security, but what can be embedded within local community frontline organisations. There's anchor public services and community services where there is that sort of no wrong door kind of approach. So better funding of local advice services, better integration between local services so people know exactly where they need to turn to try and prevent and tackle those root causes of hardship that we see. So rather than coming to a food bank first, they're actually getting the advice and support they need to get access to mental health care, to get access to housing advice, welfare advice, and so on. And then the sort of second bucket, if I can quickly skip through because I suspect I'm running out of time, but a second bucket is really about targeting some additional support to those groups who I was talking about earlier. So there is more that we can do in terms of providing more effective, quicker social security support to disabled people, for example, better employment support that we can give sick and disabled people so they can manage health conditions alongside work. and better support for families with children, particularly through social security. And then the third bucket is really the kind of some of the wider foundational stuff. So there are two kind of things I'd pull out there. One is around job security, which I mentioned before. There's more that can be done about workers' rights and enforcing those rights. And two is around social housing. It's the most affordable form of housing. Housing is often kind of the root cause of lots of knock-on effects in terms of financial hardship, that threat of eviction, poor quality housing. We think that getting that bedrock of a safe and secure, affordable home would be the kind of starting point for a much more financial secure future for lots of the people that we see. So I will end there.
Brilliant. Thanks very much, Sumi. That was an excellent start and perfectly on time. So the three kind of big buckets that you mentioned were about ensuring sufficient income, which is particularly looking at social security, reducing the impact of deductions. Really good point there, and about the benefit cap as well. Targeting additional support for disabled people, for families with children, really very much about that targeted support. And then the third one was looking at job security and social housing as well. So excellent. Thank you very much for getting those on our agenda. I'll move on to introduce Jessica from IHE. Jessica, would you like to go ahead and start with sharing your slides as well, please? Thank you.
Hi, yep, sorry, slightly finding the slides moment. Thank you very much. Thank you, Sumi. And I'm just going to start again, as Sumi did, by overviewing where we're at, which is not a happy place. And in the context of this decision, perhaps we can think of it as what not to do for the next government. Because we know that inequalities in health have really widened since 2010. We've got a lot of data on that. Life expectancy has stalled, and you're probably familiar with this notion that life expectancy is stalled, but it's really quite staggering to have seen that. We were used to increases in life expectancy of 1 year every 4 years, and that's been a pretty constant trend since at least the Second World War, where we've got good data. So absolutely staggering that we can say that even pre-COVID, life expectancy in this country had stalled. And we know that the conditions of society are expressed very well in health. If society is not functioning well, health is damaged, and that is exactly what we've seen. And we've seen these widening inequalities in health. And actually, we expected to see some widening inequalities in health because of widening social and economic and other dimensions of inequality widening. But to have seen that expressed in health so clearly, I think has come as a really unwelcome shock, even to those of us who are very immersed in this arena. Just to point out some of the data that we've recently produced. When you look, this is inequalities within regions. So we've mapped by region the state of inequalities within those regions, and you can see that since 2010 to 12 and 2017 to 19, those inequalities have widened across the country, particularly in the north. Northeast has seen the biggest increases in inequalities in life expectancy within that region. So the Labour Party have committed to reducing regional inequalities in healthy life expectancy if they're to form the next government. That is very welcome, but we also need to look within those regions at what's happening, because there have been these staggering increases. And we know what's happened in relation to inequalities. So these are excess deaths between 2011 and 2019. And you can see the most deprived on the left-hand side, by far, and there's very close gradient in excess deaths, by far the most excess deaths among males and females in the most deprived areas. So these are deaths that we hadn't expected to see if trends had continued as they were in 2010. So 138,000 more excess deaths among the most deprived communities that wouldn't have happened had we continued with the trends we were seeing in 2010. So And then within local authorities, of course, and some unexpected increases perhaps in rural areas, in the wealthiest local authorities. So Kensington, Chelsea had the biggest increase in inequalities in life expectancy 2010 to 2019. So we're only looking pre-pandemic here. We can't blame the pandemic or the war in Ukraine or any of these other factors which are held up as accounting for what's happened. You can see staggering over 5-year increase in inequalities in life expectancy in Kensington and Chelsea. And we've got a number of local authorities in rural and conservative and wealthier areas where we've seen these staggering increases in life expectancy inequalities. No surprise, of course, when we think about what the policies of austerity and subsequently have been. Public expenditure is 188 billion less at today's prices than it would have been had it carried on at the trajectory in 2010. 188 billion. Had the steepest rise in child poverty among 32 OECD countries. We rattle off these statistics all the time. Cumulatively, I mean, I could go on all day. I sometimes do, but you know, cumulative, the impacts of these cuts and these terrible trends have really made their mark on health, as I've pointed out. And this graph on the left shows government funding to local authorities. Each of these dots is a local authority, and we've correlated it with life expectancy. So those areas with lower life expectancy down the bottom left-hand side of this graph have had by far the greatest cuts in local authority spending. And look how neat that association with. This is purely regressive. The lower the life expectancy, the more deprived the area, the steeper the cuts. So the first thing that we would say, and you can see this kind of trend in funding allocations on many dimensions. We're looking here at local authority spending, by the way, right down to 50–60%. For those of you who saw the debate last night about local authorities going bust and Keir Starmer and Rishi Sunak discussing why that might be and the politics of that, look here at these funding cuts, 50–60% reductions in funding to local authorities, by far the greatest in those more deprived areas. We need to flip that graph and have investments in those areas that need it most to meet the need and to stop those impacts on health. And of course, we have our 8 Marmot principles, and we set those out initially in 2010 in the original Marmot review. They've stood the test of time. And under each of these headings, we look at trends across the country. We can see outcomes getting worse, and we have made over many years hundreds, if not thousands, of recommendations under these 8 headings about what to do. We know what to do. All of you will have good ideas about what to do. Sumi's just set out areas to do act. I'm not going to go through all the recommendations we've made in these areas, but there are hundreds of well-evidenced, well-supported, well-accepted recommendations about what to do nationally, locally, and among many sectors. So we talk about the principles that we need at the heart of the next government. Put equity of health and well-being at the heart of all policies, and you will see if we'd done that, we would not have seen the outcomes that we've seen. We would not have seen those regressive policies and funding decisions and allocations that we've seen. So as a principle, put equity of health and well-being at the heart of government. Prioritise equity and invest and design policies accordingly. Prevention, of course. We need to have a far greater focus on prevention in all programmes and policies in all those areas, those 8 areas I just outlined. Very difficult for government departments to do that because of the requirements about making the case and the short-term cycles. We know that, but I think there's now enough evidence about how cost-effective and just and beneficial it is to invest in prevention and take action before we're at crisis. And this kind of crisis management, firefighting approach to government just doesn't work. Action on the social determinants of health, those 8 principles. Rebuild the social fabric and public realm. One of the consequences of the cuts in the last few years has been this denigration of public and the diminishment downgrading of the public realm. So we need that change. We need to articulate the benefits of public shared values, investments in public infrastructure of all kinds, and in public social infrastructure, of course, as well. And we know that this endeavour has to include all of society. It's not just for national government. We need to include business and the economic sector, often left out of discussions around health equity, voluntary community sector at the absolute heart of this, healthcare, public services, local regional government, of course, and communities themselves. This is an all of government society. And we need to articulate, and for the leaders to articulate, that society is really working and the economy is working for health and well-being, not the other way around. We're frequently told that poor health is damaging the economy. Actually, the economy is damaging health. We should be working for better health and well-being. Let's think of it in that way, and that would mean that we're all those sectors, all those financial investments are working to improve health and well-being and ensure greater equity in that. And we need stronger leadership on this, that's for sure, for it to be articulated. And we cling to this. The next Labour government, in one of their mission statements, the Labour Party said that they would amplify the approach of the marmot cities. So we've been working with over 45 local authorities and a whole range of sectors who are taking action even without a supportive national context, despite all the damaging policies to prioritise health equity. And we've gained a lot of encouragement and knowledge and know-how about what to do to tackle health inequalities. So we really hope, please do this as well, but we kind of have the expertise to enact those policies that I've just outlined. Thank you.
Excellent. Thank you very much, Jessica. And really, really good. Thank you. 6 points I noted. So prioritising equity, prevention, investment in prevention, action on social determinants of health, rebuilding the social fabric and public realm, really interesting on that. It's an all of society endeavour and looking at leadership as well. Really good stuff. And I think someone was asking about slides. We will make them available on the network after the meeting, as well as the recording of the presentations. Really good. Thank you very much, Jess. Hannah, Chief Exec of Deputy Chief Exec of Northern Health Science Alliance. Would you like to start, Hannah? Thank you very much.
Thank you very much. And thanks very much to Jessica and Sumi. They were really interesting. And I'm sure you'll not be surprised to hear they're not hugely different in what we believe needs to be done to tackle health inequity. So I'm from the Northern Health Science Alliance and Health Equity North, which was born out of the Northern Health Science Alliance. We're an alliance of universities and hospitals across the north of England, and people working both at the coalface, as it were, and in research, looking at the health inequalities, the poor health suffering across the north of England. And so we came together kind of organically and focused on these work themes, so health for wealth, because working with government is something we've always tried, or influencing government is something we've always tried to do, and we recognise that cost of ill health, but also the fact that ill health costs more, and you get into a negative cycle, which speaks to all the productivity. Health resilience, well, if you need to improve the health of the country, you need to build the resilience, and with particular focus on Child of the North. And we run an all-parliamentary party group called Child of the North, and that's a research project together with the N8 universities. So these are some of our academics just briefly working on it, and worked with many of you and with the Institute of Health Equity. Michael Martin and Professor Claire Bamborough gave evidence to the COVID-19 inquiry, for example, on the impact of ill health and COVID mortality. So my first thing to ask for government is, one, we need to recognise health equity as a key goal for the future of the country. It is interwoven into our future, and whether that future is a positive one or a negative one. And it costs. Massively. So our health wealth report that we did in 2018 found that if you brought the health of the North just up to that of the rest of the country, you'd put an extra £13.2 billion into the UK economy. We also found that productivity is lower in the North. Long-term health conditions lead to economic inactivity, and a key reason for the productivity gap is that health is also worse in the North. We also found some interesting anomalies which speak to the social determinants of health. So, for example, if you experience a spell of ill health in the North, you're nearly 40% more likely to lose your job than counterparts in the rest of England. And the cost of ill health. So again, we went back to those train lines, and you can see we looked at the mortality rates in the first 3 months, and COVID started in the north, but became very in the south of east of England, but spread and became deeply entrenched in areas of deprivation across the north of England. So that's high mortality rates in care homes, in poorer areas. The north, which has overall more deprivation, and we recognise there are huge areas of deprivation across the country, just simply we have a lot more of it. It costs mentally, it costs morally, and it also costs economically. So tackling ill health should be a no-brainer for government. And we need to recognise that place is important. We take a northern view, but we also know that it's more than the north of England. Some work we did for the Left Behind Neighbourhood All Parliamentary Party group. I like to show this slide because it challenges a lot of lazy but still really widely held beliefs that ill health is due to personal choice and it's people's personal circumstances, and that they should just pull themselves together, and it ties into narratives around benefits, scroungers, etc. But we found that people in left behind neighbourhoods that are the most deprived and least community structures, so for example, access to bus services, GPs, good parks, clean air, work an hour more on average than those in the rest of the country, but are twice as likely to be out of work due to ill health. So place is important in tackling health inequity, and the government needs to recognise that. We see it in reports. We can look at it in different ways. Poverty is an overriding underlying reason why health is so poor, and the inequities that Jessica pointed to in welfare funding from local governments, that plays out all across the north of England, where Blackpool had welfare cuts of £690 per person compared to £190 per person in wealthy Cambridge. So that absolutely plays out. And then we are a good decade or so on from austerity. We are seeing babies live more infant mortality. We are seeing huge amounts of economic inactivity due to sickness or disability in the north, and 3 northern regions point above average levels of care provision, at least 50 hours per week for unpaid carers. So there is a huge, the knock-on effects of ill health escalate and escalate unless we do something about it. Like Jessica, we've got lots of reports with a lot of recommendations in, and fully support the Marmot principles. We came up with our own evidence-based missions to tackle health inequity, which again work together with Marmot principles and with recommendations. So we need a national strategy to reduce health inequalities, which is achievable. And we've looked, and it's an achievable aim to reduce the health gap by 10% between the most deprived areas of the country and the national average. And that's through addressing wider determinants of health, including education, poverty, productivity, employment rates. We need to tackle poverty. We've done a lot to increase poverty in the past decade or so, and that needs to be reversed because we are seeing the economic ill effects of that. I mean, it is a no-brainer: strain on the NHS, lower productivity, etc., etc. Give children in the north, this is everywhere, but enough food of good quality. And there are things that can be done straight away from the government. So why don't we auto-enroll all eligible pupils in free school meals and actually extend that to all kids on universal credit, get rid of that 2-child cap, and auto enrolment into the Healthy Start scheme. There are immediate things that can be done. Give people warm homes of a good standard. The state of housing in this country is abysmal and needs to be improved. There's been a lot of conversations, and we have had conversations around Sure Start centres. There isn't going to be a new Sure Start, but there will be new hubs to improve family health, and I think that needs to be invested in. We looked at and we found that if you brought up the level of Sure Start funding to what it used to be across the north of England, this is north of England only, you'd actually put another £200 billion a year into funding family hubs or centres for young people. Fund schools in the north of England fairly, support communities and families to access health and social care easily, and give people in communities that are not often consulted a voice. And I think this is something that we found when our reports is that there is a lack of research and there is a lack of accessing those people who need help most. So there needs to be something about going into the deprived communities, going in and actually investing in and finding out about people and working with them. We've got a lot of potential when it comes to data collection and analysis that we can use in a really positive way to improve health. But most importantly, we need to give those people a voice. So thank you very much again. I'm really excited that so many people who care about this, and this is such an excellent network. And let's keep putting whatever the new government is, let's keep them to account when it comes to addressing health inequalities. Thank you.
Excellent. Thanks so much, Hannah. Really good. And things I noted there, particularly in national strategy on health inequalities. And I was at DPH when we had a national strategy some 10, 15 years ago, and it had an impact. Tackle poverty, food of good quality, warm homes also to a good standard, hubs to improve family health, funding schools, particularly in the north of England, and giving people a voice, which is what we're going to do in a minute. So really good stuff. And there was interesting that you pointed out that there's some immediate things that could be done as well. So I'm going to open it up now to invite people to tell us what their priorities would be. You've heard, how many there? About 25, I think, something like that, 20, 25 priorities. What would be your priorities in amongst those, or any other comments that you'd like to make about anything that you've heard so far? And I think, is it Helen who's first up? Go ahead.
Thank you. Really great presentation, getting to the nub of the problem and some great data and facts for us to all use and build upon. Thank you. I think how can we measure prevention? It's a really difficult and tricky thing. How can we measure reductions in health inequalities? And I can see some nods. And you know, it's a real slow burn. And for us at Nutriri, we found a particular focus that would sort of like give some quite quick feedback. And we think that what we focus on is really intersectional, probably the most intersectional and unprotected characteristic. So, you know, you can be in any health group, in any protected characteristic group, and the parameter of body weight is and the stigma associated with body size is really impacting health equity. So I think, you know, a good way to measure prevention and also measure the rebuild of trust and engagement is through measuring engagement levels, and that happens by first stopping trying to solve obesity, and actually make prevention about prevention of ill health. And certainly when it comes to weight, you know, make prevention about not preventing obesity, because big bodies exist and we need the same level of care and access, and that, you know, not the discrimination that we currently experience. So, you know, I'm here as a lived experienced person, and what we've done over the last 9 years has you know, gathered people that have experienced uninvited weight talk, weight stigma, call it what you like, and also the experience of those that are tasked to talk about weight in their job roles in healthcare. So and we've started to build something, that needs support. What we're doing needs real interest and support, and it's starting to get that. So yeah, I think my comment is about, I think health inequalities and prevention specifically is a really tricky thing to measure. And there's so many people doing fantastic work and there's fantastic services out there, but the public relations side of it, you ask anybody, they will say that the healthcare service prioritises weight loss for health, and we've got to move ourselves out of that route.
And we have you were able to present on your work in May when we had the webinar, and that's on a recording if people would like to look that up. Really good points made there. Thank you very much for that. I'll move on to Deborah.
Hi, I'm in Public Health Scotland. I've really got a question more than anything. So I guess I'm caveat this with desk-based research, I think. And I struggle with, I was looking at the report that you'd put a comment, a link to Hannah, and in there it talks about to be successful and sustainable, levelling up must be led by local people, reflect local needs, etc. And that seems all absolutely crucially necessary. But what I struggle with is then one of the key things, if we need to boost productivity, pay, jobs and living standards as the key determinants of health, they're national level drivers. And sometimes I feel as if, are we setting local communities up to fail by saying, right, you've got the power, we're empowering you to increase productivity. We're empowering you to increase the labour market demand, etc. And I just don't know how that happens. And so I'm really struggling with that. I have done for a while. So I'd be really interested in any points.
Excellent point, Deborah. Hannah, would you like to come back on that, but also Jessica and Sumi in a minute?
Yeah, I mean, absolutely. When you look at the chronic underfunding of the regions, and this is why we tie these things together. So there's chronic underfunding of welfare, and it's disproportionately cut the north of England. That has also happened when it comes to schools. Schools have been underfunded in the north. There was an excellent programme in London which really helped outcomes in schools in London. That didn't exist in the north, and a lot of that was down to funding. And you absolutely cannot separate these things. So that's why we'd like a health first strategy as well across all departments, because that is so fundamental. And you can't put the onus on local people to sort out their problems when they are so massive and so related to decades of underfundment, collapse of heavy industry, and disinvestment in the NHS, etc. But what you do find is that it's a lot of the on the ground people, such, for example, food banks, who we have representatives here, who are very impactful in their areas. So there needs to be this balance about giving local community groups and local communities that know where need is best placed immediate. And a lot of that's firefighting stuff. And then there needs to be proper national investment in improving jobs and improving conditions. So they can't exist separately. And that has been something that's happened with the current government in occasion, is, we've given you a bit of power, so therefore everything's fine and it's your fault, whatever hasn't happened. So that needs to be very much articulated.
Excellent. Jessica or Sumi, anything to add about national recommendations and local involvement?
I do think we've learned a lot over the last period where we haven't had a national health inequality strategy. We haven't had national policies that's appropriate to reduce health inequalities. And local areas have done a lot, and local communities have contributed a great deal. There are limits, obviously, within what you can do within the national context. But I think building on the good examples and experiences that have been built up of working without national government really do give an indication of what can be done. And local areas, often led by local authorities, but not always, have done a lot and learn even within the local authorities. There's huge variations, obviously, and different groups who are affected the most and different areas which have, you know, pockets of deep deprivation and so on. So this locally defined and controlled within a more supportive context, I guess, would be the ideal way forward.
Thanks, Jessica.
Yeah, I think one of the trickiest, the kind of biggest conundrum, I think, is the mismatch between devolving powers and the funding that accompanies those powers. And it's something that we come up against a lot. And if a Labour government comes in, they have talked more about devolution, but at the same time, they're talking about all of their fiscal constraints. And I think that is a worrying sign if we get caught up in sort of the words, but then not the resources to actually deliver. That being said, I think, as other speakers have said, I think there are practical examples that we could do more to share kind of best practice. So from a kind of frontline organisation perspective, there are food banks that are doing really great work in terms of you know, working as hubs, working really closely with local health services as well as other frontline organisations that whether that's kind of light touch signposting, but more and more kind of really integrated like co-location, you know, very clear referral pathways, things like that, where there is a lot more joining up locally, and it hasn't been masses of additional funding, but just changes into the way they're working and the way that they're working in partnership. Some of that, I think what we find is it needs local leaders to engage with that, and it's hard if there isn't that local leadership who is kind of on the front foot with some of that stuff. And that can act as a bit of a barrier. Sometimes that's local authorities, but also it might be other organisations kind of stepping up and taking on that role.
Excellent, thank you, Sumi. I'll go to Abdul, and then I'll invite Joe to speak after Abdul, and then Sue. And Rose, if you wanted to speak again, I think your hand's not up, but do put it up again if you want to. Abdul, first of all.
Thank you, Alan. I'm Abdul. I work for the Manchester University and Foundation Trust as an equality and diversity lead. So we are the largest NHS trust in the country. So I'm working within the trust, and we are one of the Mammoth City. What I have found, the health inequalities is like boiling in an ocean. So when I say boiling in an ocean, things are just in the cloud. No one knows who's responsible for what. So when it comes to the sense of responsibility, I think one of the key themes that I've picked from the speakers that is not embedded at policy level. So health inequality, we are saying, is having a strategy. Excellent. We are good in identifying health inequality, but I think who is responsible, who is accountable of actual deliverables, and we only get that as a provider. We only get the sense of being accountable when it's embedded in our commissioning contract, when it's embedded in the legislations. So otherwise, people, you don't get that sense of delivery that, okay, this needs to be delivered really. I know there are moral reasons, there are economic reasons, but I think historically, this is what I've found, that, okay, this is part of regulation. We need to achieve that. For example, we do have a core 20+5, but I think who is accountable, who is responsible, what are the key? I think when I say it's about boiling the ocean, is what are the actual small steps that we can't change, we can't bring 100% perfection within the system, but I think what are the small steps that can be achievable.
Great, thank you very much, Abdul. I think all NHS trusts have to have a statement on health inequality as well these days. Jessica, would you like, you have leadership as one of the 7 asks, would you like to pick that point up?
Yeah, I think you're absolutely right. I mean, accountability on health inequalities is so weak, even where there is legislation, for example, the Health Inequalities Duties, even Social Value Act, the accountability is quite weak, and it's not been, the Health Inequalities Duties are, as far as I know, never been tested legally. They drive a focus and attention, which is good and helpful, but I do think that we need accountability, and certainly for inclusion groups, I think that there needs to be direct accountability lines. But you're right in that health inequalities generally is so diverse that it lacks accountability, and it lacks that kind of system direction often. we had a conversation involving Martin Reeves, who was chief executive of Coventry for a long time when it first became a Marmot Place the other day. And his advice, as far as I understood it, was just do something, start somewhere, do not wait for permission and do not wait for the legal requirements. They will follow potentially, but just start and do it and bring people along with you. And he's been a very strong leader on these issues now at Oxford County Council, so doing similar things. So I think that was also some good advice from him, is we just need to do it even without the enforcement and the regulatory framework that's helpful.
Thanks, Jessica. Can I invite Joe Farrington-Lewis, Douglas, to pick up the point made in the chat? Thanks, Joe.
Yeah.
Oh dear, and at that moment, I think Joe's frozen. On the assumption that Joe will get back into us again, can I go to Sue Malik?
Hi, I'm unmuted. Can you see me? I can't.
Yes.
Oh, good. There are a number of things that I'm the chair of something called BBUP Fosley, which has been addressing rural inequalities since really 2017. And I think, I've been an academic and being involved in, I was involved in Sure Start and also evaluating that about 15 years ago. And I think we've got to find a better way of assessing the impact of community-based initiatives which are not focused on targeting particular people who happen to be on drugs, smoking, whatever. I mean, our approach has been to attract people into activities that have been very, very successful, that involve children and adults, and have had the impact of a whole range of arts activities. They're all free, has reduced isolation, is initiated lots of networks around send, offending, etc. They've got, so there's spin-offs that arise from the community wanting certain things to happen, but over 3 years, we have had an impact on people's confidence to start thinking about maybe getting a job, to start thinking about a sort of taste, sort of, it's not really just about health. It's absolutely about involving people in activities that help them have the confidence to move from where they are at the moment and feel better about themselves and build confidence in the community. Now, I have a lot of contact with the public health director in Salford, who I'm a great fan of, called Muna, who's actually got a very similar approach to her role as the public health director in terms of working with communities to actually lift themselves. And sometimes we move from thinking that we really want to do something about inequalities and then going back to very traditional ways of targeting it, particularly within the health system. So I'm in rural Devon, but quite often One Devon then puts the money into, put a lot of work into tackling national targets, etc., the health, etc., and actually undermines the community initiatives that are going on. I mean, it's a very complicated picture, but if we could just get more recognition about actually ways in which self-motivating, participative action in a local community can do a whole range of things, and we need a narrative around that actually contributes to it, which it gives weight within policy making locally as well as nationally, and combats a sort of ethos at the moment, which is agreeing to all sorts of things on paper, and then actually the activities that are funded by the existing system, within the regions, wherever it is, revert, because they're the things that they want to measure. And quite often the medics down here sorry, I'm sorry to go.
Okay, just a few more seconds.
There's a lot of points in terms of the things, the lack of a way of describing the impact, the social impact that community-based activities has, is a problem.
Excellent. Well, thanks, Sue, and particularly about that narrative that we need. So, Joe, there was a glitch earlier, but please go ahead.
Yeah, I know sometimes happens. I just wanted to say that, like, I think there's an opportunity, like in terms of kind of top priority, an opportunity to latch onto that health mission in the Labour manifesto, that we could have some cautious optimism that it is actually there in the top 5 missions, although they haven't really talked about it, certainly not in any of the campaign. And I'm very aware that we've had a health or a levelling up mission since about 2017, but not actually connected to any mechanisms to deliver it. So we need to make, if this new government comes in and actually has this in their manifesto, that we make sure that that is this time connected to real mechanisms. Like they've talked about having a mission delivery board that needs to have the backing of a central unit to facilitate that working across departments and to develop and negotiate with all parts of government the strategy to actually achieve it, and to define targets, and the Health Equity North report on defining a target for health inequalities should really inform that thinking, and needs to change the way that funding is allocated by the Treasury so that prevention is sort of seen as an investment rather than another type of spending along with cure, and ultimately we should be calling for a piece of legislation that would really underpin that, so that it's kind of put into the bricks and mortar of government. Like to some extent, the Climate Change Act has had some traction. So that's that kind of pitch for like making those cross-government mechanisms much stronger if we get a chance with the first sort of few months of a new government.
Excellent. Thank you very much, Joe. It really good ideas about consolidating health equity at the heart of government. Mahmood.
Yeah, hi, Hashim. Just a couple of quick points. So I think there's something around sort of that dissonance between sort of national sort of accountability and priorities, and from a sort of health and care sector process. A lot of sort of what is talked about is kind of some of the acute challenges and pressures, and how do we sort of align that with some of what we've sort of been discussing here, is around trying to tackle health inequalities and looking at prevention both from a primary, secondary, and a sort of tertiary lens. I think that sort of kind of it is something that really needs to be ironed out by any sort of new administration coming along. I think also there's something around we've not really mentioned sort of the concentration of risks. So I think, yes, there are sort of the lifestyle issues, but then I think how they're sort of impacted on the wider social determinants that influence sort of health in individuals and communities. And what I was sort of looking at when looking through the manifestos is actually that sort of notion and recognition of the epidemiological shift towards sort of multimorbidity, and how that sort of really needs to be incorporated in any sort of kind of health improvement policy going forward. And then finally, I think there is a mention, which again Jessica alluded to, the healthy life expectancy sort of inequity, and how we can reduce that by a half. And I think we really need to be sort of kind of a bit more realistic in that vision, because looking at past sort of trends, I think it's been quite static over the past sort of 10 years. But I think groups like this and forums, how we can sort of influence some of that thinking within a new administration, and provide some of that analytics to really set targets and outcomes that are realistic, but sort of centrally embedded in a cross-governmental approach, as sort of Joe alluded to.
Excellent. And when you're working at local level, there always is a call for data to show that you're having an impact, and having some targets is part of that process, I think. Thank you very much, Hashim. I'm going to give final word to Deborah Shipton, who raised a very interesting point in the chat. Deborah, are you there? Can you pick that up again?
Yeah, I guess it's the issue in the chat was about wealth inequalities. So we've got growing economic inequalities, and wealth inequalities is bigger than income inequalities, from what I understand, and it's just phenomenal, the amount of wealth inequalities. And I just wonder that should everything we say be prefaced with that, because if it's all about resources, we talk about, oh, we're not getting resources to the north, etc., the schools, they're all like regressive sort of resource allocations. And instead of saying we need to, it's important to have it non-regressive, but if the money is constantly being siphoned out, all we're doing in a way is, not all we're doing, because it's everyone gets out of bed and tries to do really important things, I don't mean to say that, but is like a single message. It's wealth inequalities. The message is there isn't any money. There is money. There's phenomenal amounts of money, and it's siphoned off. So during the pandemic, the wealthiest got phenomenally more wealthy. And so it's about, I feel as if a single message, we can have our own individual things. I've got my own interests, but everything at the beginning of that is we need to tax wealth. We're not economists, we don't need to say how, but we need to tax wealth, and then we need to look at food banks, we need to tax wealth, and then we need to look at alcohol, we need to tax wealth, and then we need to look at whatever. Anyway, that's what I think that we should all say.
It's a great point. Thank you very much. Would either Hannah, Jessica, or Sumi like to come back on that point? And
yes.
Thank Jessica
you.
And then Hannah.
Yeah, I hope we end on that point, because yes, we've talked previously about, we gave it some formal language around progressive taxation, which is basically to your point. Realistically, given what's been said in the election campaign, we're not going to get that from any of the main parties. I do think even without that, there's a lot that you can do in just shifting those allocations. And not widening inequalities, in fact, addressing them. But yes, point taken. Very well, thank you.
Thanks, Jess. Hannah?
I agree with what Jessica was saying. I think that, yes, there needs to be more wealth put in the right places, and we've seen a decade of it being put in places that didn't need it as much, or taken away more from the right places. And yeah, there needs to be health in all policies. There needs to be targets to hold people, the government, to account on this issue as well. And we need to make sure that it's continually advocated for, and that the future government can't get away with not addressing this, because it's fundamental to the country.
Thank you very much. Thanks very much to everyone who posted in the chat some really interesting points there and links as well. Thanks very much for the questions. Thanks especially to our three speakers, to Sumi, Rabindrakumar, Jessica Allen and Hannah Davies. And this time next week, it'll be the election. Let's see how that goes. And hopefully see you back again in a month's time for our next monthly webinar. Thank you very much. Bye.
Thank you.
Thank you.
Thanks so much.
Thank you.